So welcome all of you, and I request our President, Dr. Arti Nimkar Madam, to address before starting this cardiac update. Thank you.
Good morning, everybody. I welcome you all for this webinar on the cardiac update. Uh, up till now, we were worrying about the COVID-19 and cardiac symptoms and respiratory symptoms of the COVID, and we are relating all these symptoms with the COVID. But now we have to be separate ourselves from the COVID and think about the normal situation in the cardiac uh, patient and respiratory patient. And now we are having the eminent team of the cardiologists to get updated to us in the cardiology. Dr. Sachin Yadav is going to talk on the care and outcome for the and improvement for the patients with the ST elevation in myocardial infarction. Then Dr. Krishna Dut is going to speak on the post-angioplasty management of the antiplatelet in recent advances. Dr. Akash Mudgi will speak on the NOVAC in management of the deep vein thrombosis and pulmonary embolism. Then Onkar Thopte will speak on the COVID-19 and MI, and Dr. Sachin Lakde will speak on recent advances in management of the heart failure role of the HGLTI. And I request Dr. Sancheti to go ahead with the introduction of the speaker.
I welcome Dr. Sachin Yadav, sir. He is the first speaker. Sir is MBBS and MD from Vijay Medical College, Sasun Hospital, Pune. Sir stood first in MD Medicine, Pune University, 2002. Worked as intern in Inlax Budrani Hospital. He had served at Nasrapur in 1998 as a medical officer and Shirwal PSC also. Sir has been trained in intensive care training under the guidance of Dr. Prachi Sathe, Ruby Hall Clinic, worked as a lecturer in Bharati Vidyapeeth Medical College for about 5 years, 2003 to 2008. Presently a medical director at Chintamani Hospital, which is a 53-bedded multi-specialty hospital with ICU, cath lab, dialysis unit. Working as a consultant physician, diabetologist, critical care in Chintamani Hospital for last 15 years. Did his PG in Diploma Diabetes, Cardiff University, UK with distinction from 2014 to 2016. There was also a past president of PDA and well known among South Pune doctors. Now also is very active member of hospital board for fixing rate committee, member of Association of Nursing Home and all the clinics, taking lectures and CME of various doctors and hospital staff since many years. Public speaker for awareness of diabetes, hypertension, HIV, speaker in API, various doctor local associations also, chairman of PediaCon since successive 2 years, published 2 papers in JAPI, attended many national international conferences and well-known speaker also, attended workshops on critical care, thyroid, HIV, asthma, COPD, 2D echo, EEG, conducted phase 3 clinical trials for hepatitis B vaccine, etopride, and as a principal investigator for formoterol, budesonide inhaler combination, completed his training in ICH and GCP required for clinical trials. I request, sir, to address about his topic. Please, sir.
Thank you, sir, for giving excellent review of my biodata. And thank you, Hruday Sparsh team, for giving me this opportunity. Thank you, Dr. Arti Nimkar, Madam, the President, IMA Pune, Dr. Sancheti, and all the delegates. So good morning, everyone. So I am going to present the topic on the myocardial infarction. As you know, during COVID time, initially, the patients of myocardial infarctions were reduced. Definitely all cardiologists will agree. But now post-COVID, we are getting the patients, most of them, almost 50% of the patients, they have the myocardial infarction. Initially, even the cardiologists were afraid to do the primary angioplasty because of the risk of transmission of the COVID. So today I'm going to discuss on the medical management of this myocardial infarction. So I will just share my screen. So today I'm going to discuss the improvement in care and outcomes for patients with ST elevation myocardial infarction. And this is especially in reference to the Indian context and the COVID situation. Still, we are getting patients who are COVID positive and they are coming with the acute coronary syndrome. So as you know, the coronary heart disease accounts for most deaths from the cardiovascular disease. So if you see, almost 7.2 million deaths are because of the acute myocardial infarction all over the world. So acute coronary syndrome consists of the spectrum of clinical conditions ranging from unstable angina, then non-QA myocardial infarction, the QA myocardial infarction, or the ST elevation myocardial infarction. And all these have the common pathophysiology of the disrupted atherosclerotic plaque. So patients who come with the chest pain, typical ECG changes, or the raised cardiac enzymes, they are classified as the acute coronary syndromes. So any two, either chest pain, ECG changes, or the raised troponins or the CPKMB, they are classified as the acute coronary syndrome. Then patients who do not have the ST elevation, they have the ST depression, T wave changes, they are classified as the unstable angina or the non-ST elevation MI. Those patients who have the STT changes and troponin positive, they are classified as a non-ST elevation MI. Troponin negative, they are classified as the unstable angina. And in all these patients, we have to do the repeated ECG, we have to do the repeated cardiac markers. Then only we will able to classify as the unstable angina or the non-ST elevation MI. In cases of the ST elevation, the diagnosis is clear-cut, usually on the ECG or even on the 2D echo. So in these cases, the cardiac enzymes rise later, and we have to treat the patient before the reports of these cardiac markers are available. So they are classified as a ST elevation MI. So today we are going to discuss the ST elevation myocardial infarction. So time is money, like the time is muscle. So patients who have the coronary artery blockade, if you do not reverse the blood flow within time, the muscle is damaged and the heart function decreases over a period of time. So if you see this diagram, so red one is the normal muscle, then orange is the ischemic muscle. So once the artery is blocked or the blood supply is hampered, we get the ischemia within 15 minutes. If you don't, if the blood supply is not reversed or it's not established, then the necrosis starts within, from endocardium to epicardium. So depending upon the time duration till the blood supply is established, the necrosis sets in. So the best time to revascularize or best time to give the reperfusion therapy is up to the 3 hours, because up to 3 hours, almost the 50% of the myocardium is necrosed. So after 6 hours, most of the myocardium is necrosed. So no much benefit is received even we give the treatment after the 6 hours. But some patients do have the partial obstruction and they get the persistent pain, and that lasts up to even 12 to 24 hours. In these patients, even this patient will get the benefit if you revascularize such patients within time. So as soon as we do the diagnosis, we should give the patient the revascularization or the reperfusion therapy, because time saved is the muscle saved. So this is how the thrombus of the non-ST elevation MI is seen. So patients who have the platelet plaque, they will have the non-ST elevation platelet plug, they will have the non-ST elevation MI. And initially we will have the working diagnosis depending upon the patient's symptom and the ECG. And later, once the biochemical markers are available, we can do the final diagnosis. But in cases of the ST elevation, we have to act very fast and we have to give the treatment before the cardiac markers are available. Because if you don't treat the ST elevation MI fast, the patient will get the QA myocardial infarction and the muscle is necrosed. So how do we treat the acute coronary syndrome? So initial treatment of acute coronary syndrome for the STEMI and non-STEMI is the same. The dual antiplatelets like the aspirin, Clopidogrel, Ticagrelor, or the Prasugrel, if the patient is to be taken for the cath lab. Then anti-ischemic drugs, the nitroglycerin, then anticoagulant therapy, heparin, either regular heparin or the low molecular weight heparin. And if the patient is having the ST elevation MI, these patients can be thrombolized if the cath lab is far away or the time duration is more than 2 hours to reach the cath lab, or patient can, if the time duration is less than 2 hours, then patient can undergo the primary angioplasty or the even the CABG. Then for the non-ST-elevation MI, the antiplatelets, then the anti-ischemic like the nitroglycerin, anticoagulant therapy, regular heparin or the low molecular weight heparin. And these patients once stabilized, or they can be taken for their coronary intervention. If these patients are unstable, persistent ongoing chest pain, the patient has the cardiogenic shock, arrhythmias, then this patient can be, this patient have to be taken immediately for the coronary intervention. So initially, before the CCU era or the ICU era, the mortality for this acute coronary syndrome was almost 30%. But after the development of the coronary care unit or the intensive care unit, because of the availability of the defibrillation, the good hemodynamic monitoring, beta blockers, and the newer drugs, the mortality is reduced to 15%. But in the era of the reperfusion, the mortality is reduced from 30 to 6.5%. So this reperfusion can be in the form of mechanical reperfusion like the angioplasty, or it can be in the form of the thrombolysis. So what are the clinical objectives in the management of the STEMI? Most important is to minimize the extent of irreversible injury. Then we have to prevent the recurrent ischemia or the myocardial infarction. We have to avoid the complications of the myocardial infarctions as well as the reperfusion therapy, because the reperfusion therapy can lead to some complications like bleeding or even the arrhythmias can be there. So here we have to manage the electrical instability. So proper monitoring is required. Then promote healing and the recovery. So all these are the objectives of the reperfusion therapy. So which is to be preferred, fibrinolysis or the angioplasty? We have the detailed discussion in the next slide. So best form of reperfusion therapy is the mechanical. So this is beyond doubt. But the outcomes are highly dependent on the expertise, who is doing the angioplasty, then logistics present in the individual institutions, then the availability of the cath lab. So many issues are there regarding the primary angioplasty. So we will see the data regarding the fibrinolysis as well as the angioplasty. But the primary angioplasty has definitely distinct advantages over the fibrinolysis, because the chances of bleeding are less with the angioplasty as compared to the fibrinolytic therapy. Then primary angioplasty achieves higher TB grade 3 flow, which is required for the reperfusion, especially in the infarct-related artery. But why fibrinolytics are still used in India? So there is benefit even with the fibrinolytics. The benefit of fibrinolytics is well established. They reduce the mortality in acute ST elevation MI by almost 30%. So even in the rest of the world, where the cath labs are far away or the cath labs are not available, then some logistic issues are there. There also fibrinolysis remains the most commonly used reperfusion therapy. So in less than 30% of the patient, if you see this data, less than 30% of the patients in the United States, which is supposed to be the most advanced country, and even in Europe, less than 20% of the patients, they have the access to the primary angioplasty, and probably even fewer. We have the data of in India, less than 8% of the patients, they have the access to the primary angioplasty. In Pune city, the situation is different, because most of the hospitals now, they have the cath lab, and patient can reach to the nearest hospital within 15 to 30 minutes. So in Pune, the primary angioplasty will be the best option for the acute coronary syndrome patients. So what is the scenario in India? So here we will see the data. So according to the Indian Heart Journal 2017, almost 30 lakhs patients of STEMI occur every year. And to cater these 30 lakh patients, we have only the 1200 cath labs, where only 3.74 lakhs of the coronary interventions take place. So this is clearly not enough. And if you see, the 34% of the STEMI patients, they are below 50 years, who are the earning members of the family. So out of which the 58% patients, they receive the thrombolytic therapy, and only 8% patients, they receive the primary angioplasty. So that's why we are discussing the role of thrombolytics in the ST elevation MI. Similarly, the patient who gets the symptom to reach the hospital, the time duration is also more. That is around 6 hours. And only 4% of the patient, they travel by ambulance, and most of the patient, they travel by their own car. And if the complications occur during travel, so most of the patients, they get a cardiac arrest during the transport. And one more thing, the patients, most of these patients, they do not have the insurance coverage. The affordability of the many patients are less. So that's why the primary PCI is still a dream for many patients in India. So in India, the PCI capability has definitely increased, but still the universal availability of primary PCI is unrealistic for most of the developing world, including the India. So what are the key barriers to primary PCI in India? The real fact is there is a lot of traffic congestion. Even in Pune, to travel 5 kilometers, it takes almost 30 minutes. Then second important thing is the lack of funds. That is the finance. Only 15 to 20% of the patients, they are insured. So that's why there is lack of funds, and the primary angioplastic cost in lakhs rupees. So that's why most of these patients, they are reluctant to undergo the coronary intervention. Then unavailability of the hospital with the PCI capabilities. There are almost 650 hospitals in Pune, but only 10 cath labs, 15 cath labs in Pune. And even if the cath lab is available, the previous intervention is going on, so there is unavailability of the cath lab. So this is also one of the important facts. And the round-the-clock manpower in cath lab, it's very difficult to get the trained manpower even in the cath lab for 24 hours, 24/7. So your primary PCI is available to less than 10% of the STEMI patients in India. So that's why thrombolytics still remain the relevant in today's medicine, and require a discussion on acute thrombotic syndrome, including the ST elevation MI. So what are the guideline recommendations? So according to 2070 ESC and 2018 ESC guidelines, the reperfusion therapy is indicated in all patients who have the symptoms less than 12 hours duration with the persistent ST elevation. Then the patients who have the non-ST elevation MI or the unstable angina, but they are having the hemodynamic instability, the blood pressure, they require the inotropic support, or the patient is in cardiogenic shock. They have the refractory ongoing chest pain, then life-threatening arrhythmias or the cardiac arrest, then mechanical complications of myocardial infarction, acute heart failure, then recurrent dynamic ST segment changes. So all these patients, they will require the PCI. PCI is the best therapy for such patients. Then primary PCI is also recommended over fibrinolysis. Here PCI is best option for patients who have the symptoms more than 12 hours, because after 3 hours, the role of thrombolytics is less as compared to the PCI. So routine patients who have the symptoms more than 12 hours, they should undergo the coronary intervention. Then patients who have the logistic problem, the cath lab availability is the problem. Then the transfer is also problem. In such patients, we can do the thrombolysis. Then PCI capable centers, they also should have the 24/7 service, and primary PCI should be performed as fast as possible, because even if the patient reach to the hospital within time, but the relatives or even the patient takes a lot of time to take the decision. They will call their family members, they will call their doctors, then they will make the money available. So all these will take a few hours. So the golden hour is lost in such logistics. So here we have to do the primary PCI as fast as possible. Then routine revascularization of non-infarct related artery should be done if the patient had multiple vessel disease before hospital discharge. So if the patient has the acute myocardial infarction, you can do the infarct related artery stenting, then before the discharge, you can do the related non-infarct related lesions should be tackled. So what are the time targets? So from the first medical contact to the ECG and diagnosis, it should be less than 10 minutes. Then the patients who get the symptom to the crossing of wire should be less than 2 hours. My patient who gets the symptom and the patient who requires the primary intervention, the duration should be less than 2 hours. Then the patient once in the cath lab hospital, then the time duration should be less than 60 minutes. Once the patient is hospital diagnosed with the myocardial infarction, the intervention should be done within 60 minutes. The maximum time from ST elevation diagnosis to the wire crossing in transfer patient, the patient who was admitted in other hospital, transferred to the cath lab capable hospital, should be less than 90 minutes. And if the patient is taking a lot of time, the financial problem is there, then you can start with the thrombolytic therapy within 10 minutes. So diagnosis for myocardial infarction is 10 minutes. You can start the thrombolytics in the 10 minutes. Then we have to take the decision if the fibrinolysis is successful or the failure. So that should be within 60 to 90 minutes. If the patient gets the persistent stimulation after 90 minutes or the patient gets the persistent chest pain, this patient should undergo the coronary intervention. So these are the drugs which are available for the stimulation MI. The streptokinase, which is a old drug, but the problem with the streptokinase is it has to be given by the infusion. Then allergic reactions are possible with the streptokinase. Then altiplase is not very commonly used, but the bolus doses of the retiplase and the tenecteplase, they are very easy to administer. And the patency rate, even the TIMI-3 flow is also good with this newer thrombolytics. So what is the initial pharmacotherapy for the STEMI? So pain relief is done with the opioids like the morphine or the pentazocine. Then if the oxygen saturation is less than 95%, you can give the supplemental oxygen. Then antiplatelets drugs like aspirin, clopidogrel, prasugrel, ticagrelor are given, dual antiplatelets are given. If the patient is taken to the cath lab directly for the PCI, then aspirin along with the prasugrel or the ticagrelor. Ticagrelor is the best drug because that is having the least platelet resistance. And prasugrel is a cath lab drug. It is not to be used with the thrombolytic drugs. Then antithrombotics like the regular heparin or unfractionated heparin. Then beta blockers to reduce the heart rate, especially in the anterior myocardial infarction. Then the thrombolytics like retiplase, tenecteplase, or the streptokinase. And the patient, if they reach in the reach to the hospital within time and willing for the primary PCI, then you can give the dual antiplatelet drugs with the antithrombotic drugs. So what are the goals of the fibrinolytic therapy? So the fibrinolysis should achieve the early patency. It should increase the myocardial salvage. It should preserve the left ventricular function and should lead to the lower mortality. The other benefits of the thrombolysis, if you thrombolize early, then it will improve the remodeling. Then it enhances the electrical stability. The chances of life-threatening arrhythmias are less, and it will reduce the long-term mortality. So what are the situations where fibrinolytic therapy is preferred over the PCI? When the invasive option is not there, like cath lab is far away, it is not within 2 hours of operation. The cath lab is preoccupied. There is lack of access to the experienced staff. And sometimes some patients do get the vascular access difficulty. There we can thrombolize such patient. Or if the there is expected prolonged delay in the transport, or the delay in the door to balloon time is more than 90 minutes. In such patients, we will prefer the thrombolytics. Even now we have the good cardiac ambulances where we can do the thrombolysis and we can take the patient to the cath lab capable hospital, which is called as the pharmacoinvasive, or even some patients do require the rescue angioplasty. So if you see this diagram, it will explain everything. So patient's delay, once the patient gets the symptom, he will call either the emergency medical services, or he will go to the non-PCI capable hospital or the primary care physician, or he will go to the directly the cath lab capable PCI capable hospital. So in all these patients, if the patients who get the first medical contact with the general practitioners or who call the emergency medical services, if the expected time is less than 2 hours, then primary angioplasty is the best option. If it is more than 2 hours, then fibrinolysis can be given, and later this patient can be subjected to the coronary intervention. And if the patient who reached to the PCI capable hospital, the diagnosis STEMI is confirmed, in that we can take the patient for the primary angioplasty. So if you see from the symptom onset to the crossing of wire or the successful reperfusion, so what is called as the total ischemic time. This is a total ischemic time, and we have to reduce the total ischemic time, because time saved is a muscle saved. So we have to reduce this ischemic time, that will improve the myocardial function. So all these thrombolytics can be given up to the 3 hours. The best results are up to the 3 hours, or it can be extended even up to 6 hours. But after 6 hours, there is no role of thrombolytics. There, PCI will score over the thrombolytics. So in the first hour, almost the PCI as well as the thrombolytics, they have the similar results. Only thing, the chances of bleeding and the TIMI 3 flow, they are better with the PCI. Then up to 3 hours, you can give the thrombolytics. But after 6 hours, there is no role of the thrombolytics. So recommended approach in cases of anticipated delays. So you can lyse the patient, you can thrombolyze the patient and stent on the same day, or you can stent the patient tomorrow. So this is called as a pharmaco-invasive approach. The situation is different in Pune, because Pune has many cath lab and they are easily approachable. So desirable features of the ideal thrombolytics: it should achieve the rapid perfusion, then 100% TIMI grade 3 flow reperfusion should be achieved. It can be given as an intravenous bolus, so we can be available to monitor the patient, we can manage the complications. Then it should be fibrin specific. It should have the lower incidence of the systemic bleeding. It should have the lower reocclusion rate, no effect on the blood pressure, no allergic reaction, and the reasonable cost. So all these are the ideal features of the thrombolytic agent. So these thrombolytic agents, they will activate they are the plasminogen activators, and they will activate the plasminogen and it will be converted into the plasmin. And this plasmin will dissolve the fibrin of a blood clot, but it may also degrade the normal components of the hemodynamic system. And that's why we get the bleeding complications with these fibrinolytic agents. So first generation agents are the streptokinase, urokinase. Second generation are the alteplase, which is very less used. Then the newer or the third generation thrombolytics are the retiplase and the tenecteplase. So these are also classified as the fibrin specific and the fibrin non-specific. The fibrin specific are the TPA, then the retiplase or the tenecteplase. The fibrin non-specific are the older one, like the urokinase and the streptokinase. All these agents are effective in reducing the mortality, but as the generation improve, there is safety as well as a greater patency rate in the estimulation MI. So this non-fibrin specific like streptokinase, they act on free as well as the fibrin bound plasminogen, and that's why the complication rates are more with the bleeding complications are more with the streptokinase. Whereas the fibrin specific, they activate the fibrin bind plasminogen. So that's why the chances of bleeding are less with these fibrin specific agents like the retiplase or the tenecteplase. So this is a graph which is showing the, so this is a clot binding plasminogen, and this is a free or the not clot binding plasminogen activator. So this newer generation, they activate only the clot binding plasminogen activators. That's why the systemic bleeding complications are less with this newer generation thrombolytics. Then regarding the ease of administration, streptokinase has to be given over infusion like 30 to 60 minutes. Then alteplase, initially the bolus, then infusion of 0.75 milligram per kg, then again infusion of 0.5 milligram per kg. So it's a difficult infusion therapy for the alteplase. Retiplase and tenecteplase, they are given as the bolus doses. Retiplase in the 2 doses, 10 units initially, and 30 minutes later 10 units, and tenecteplase is given as a single bolus dose depending upon the weight of the patient. So if you see the newer thrombolytics like tenecteplase and the retiplase, they are very easy to administer. So newer generation are better, safer, and more user-friendly than the older generation agents. So if you see, the fibrin specificity of tenecteplase is the highest, then retiplase is also good, but the antigenicity, the allergic reactions are possible with the streptokinase. Previously, most of the cardiologists were saying once the streptokinase is used, it is not to be used again. Or books were mentioning once the streptokinase is used, it is to be used after only 2 years. So nowadays, very few doctors are using the streptokinase, but where the cost concern is there still the streptokinase is used. So allergic reaction, antigenic reactions, they are possible with the streptokinase. Patient do get the hypotension, and there we have to be very cautious. We have to monitor very carefully with the streptokinase infusion. But with the bolus thrombolytics like the tenecteplase and the retiplase, the allergic reactions are almost monitor the patient, and we are free to manage the complications of the myocardial infarction. Then regarding the patency rate, the 90-minute patency rate is 75% with the tenecteplase, whereas it is 80% with the retiplase, and TIMI 3 flow is 60% with the tenecteplase as well the retiplase. So if you thrombolize the patient in first hour, golden hour, you get the similar releases as compared to the PCI. And these thrombolytics can be given up to the 3 hours from the symptom onset. So retiplase is a novel plasminogen activator which is used in the management of STEMI. The advantage of the retiplase, it is non-weight based. So in cases of the tenecteplase, we have to know the weight of the patient, and if the weight is wrongly noted, then patient may get the overdose of the tenecteplase, and the intracranial bleed chances are more with the tenecteplase. So that is one advantage with the retiplase. So retiplase, the standard dose is 10 units initially, followed by 10 units after 30 minutes, whereas tenecteplase is weight-based, and we have to give the single bolus dose of the tenecteplase. But the dose-related complications are seen with the tenecteplase because of the wrong recording of the weight. Then one more advantage with the retiplase is the lesser reinfarction rate. Some of these myocardial infarctions, patients do get the reinfarction, and that is less. If you see in cases of the tenecteplase, it is 8.5%, whereas in cases of the retiplase, 6.9%. Even in the pre-hospital use, the chances of the reinfarctions rate are less with the retiplase as compared to the tenecteplase. So these thrombolytics, bolus thrombolytics can be used even during the transportation in the cardiac ambulances. This is because the retiplase penetrates the clot better than the tenecteplase. So this is a diagram of the retiplase, which the drug is available in most of the parts of the clot, whereas the tenecteplase is available only in the superficial part of the clot. So that's why the retiplase has a better penetration, and that gives a better results regarding the thrombolysis. So we'll take a short case of 1 minute only. So this 63-year-old male who presented with a severe chest pain. This is a common scenario in the Indian situation. So 63-year-old male who presented with severe chest pain in the early morning. So chest pain started at 4:30 a.m. Then he calls the emergency medical services. Ambulance gets at 5:30 a.m. So there is almost delay of 1 hour 20 minutes. ECG was taken in the ambulance. He's a smoker, no previous history of hypertension, diabetes. And if you see, so there is a hyperacute infralateral myocardial infarction. And this was confirmed by cardiologist by the
can you sum up, please?
हाँ सर, एक 5-7 मिनट होईल सर.
Sure.
So there are major reasons for delay in the STEMI care. First is to call the emergency medical services, then transportation difficulties, then accessibility of the cath lab, which is running 24/7, then consulting relatives as well as the family physicians, that also take the delay. Then inadequate availability of ECG, then reading difficulties of the ECG, poorly trained staff, all these will lead to the delay in the primary PCI. So if you see, from the onset to get the medical care, the duration is almost 6 hours. and only 5% of the patient they are using the these cardiac ambulances. So this patient arrived in the hospital at 6:30. So if you see, the pain started at 4:30, he gets in the hospital at 6:30. It's almost 2 hours dilation. That hospital was not PCI capable, so thrombolysis was done, and it completed at 8 a.m. The ECG was repeated at 9:30, and there was 50% reduction in the ST elevation with the pain settle. Later on, once the patient is stabilized, the patient was transferred to the PCI capable hospital, which was almost 125 kilometers away. So angio showed the significant lesion, 95% stenosis in the proximal RCA. The patient was stented and patient became stable. So after 4 weeks, the patient was quite stable with no further evidence of the STEMI. So what is the ideal protocol? So patients who present with the STEMI in the big city, they should be directly sent to the primary PCI. Then in small town, you can give the hospital-based thrombolytic therapy. If the patient gets a successful thrombolysis, then you can do the coronary intervention on the same day after few hours, or patient can be sent to the cath lab second day. If there is failed thrombolysis, then this patient again require the urgent coronary intervention, and this is called as a rescue angioplasty. And patients who are in the villages, they should be transferred to the nearest possible hospital where thrombolysis is done. And after that, similar protocol like the successful thrombolysis there, the patient can be managed for 24 hours and then can be sent to the cath lab. If the patient gets failed thrombolysis, then patient has to be sent urgently to the for the coronary intervention. So important thing is the timely recognition of the symptom. You should know the symptoms very well. You should not attribute to acidity or some non-cardiac chest pain. The patients who comes at night, who has the medical comorbid conditions or high-risk patient, they should undergo the ECG, and they can even be admitted for the observation. Then second is you can make the emergency medical services robust so as to reach the patient to the PCI capable hospital within time. Then pre-hospital ECG, administration of antiplatelet drugs, anti-angiogenic drugs should be trained to the medical staff. Then timely establishment of the reperfusion either by the thrombolytics or either by the PCI. So this is very, very important to reduce the door to needle time. So patients who are diagnosed STEMI, duration less than 2 hours, they will receive the standard medical therapy and they will be sent for the either thrombolysis or the primary PCI. So early in STEMI, early routine angioplasty is best because time is muscle. But if the delay is more than 90 minutes or the 2 hours for the transfer patient, then better to thrombolize. But if the patient is patient can be transferred to the cath lab hospital within 90 minutes, then primary angioplasty is the best. And along with this, the patient should receive the antiplatelet statins, ACE inhibitors, beta blockers, and the heparin. So treatment delayed is a treatment denied. That's why we have to act very fast. We have to reduce the door to needle time, or we have to reduce the symptom to intervention time. So the patients who received the treatment pre-hospital or in the even the thrombolytic therapy, there is significant reduction in the mortality by almost 17%. Similarly, the patients who received the treatment in first 2 hours, they have the almost 64% mortality benefit as compared to the other population. So this was explained in the OPI, which is a standard textbook for the drug for the heart. So golden hour is very, very important. So if you reperfuse the patient in the first hour, the mortality is reduced from 8.7% to 1.2%. So even the infarct size also reduced from 11% to 4.9%. So intervention or the reperfusion is very, very important. So bolus drugs like the tenecteplase or the retiplase, they are the best drugs, and they are used when the PCI is not possible. So only contraindications for these thrombolytics, the patient had internal bleeding, like the patient has melena, piles, patient has undergone recent surgery, patient had history of cerebrovascular accident, or patient has known bleeding tendency, or patient is in cardiogenic shock. In these patients, the PCI would be better over the thrombolytics. So after the thrombolysis, the arterial venous puncture should be minimized, and do not administer these thrombolytics faster than the recommended. Then recent surgery like coronary artery bypass graft or the organ biopsy, we should be careful. Then the previous puncture of non-compressible vessels. Here also we have to look for the bleeding manifestations. Patient who have the hemorrhagic stroke in the past, they should not be thrombolized. Patient who had the GI bleed or the genitourinary bleed, they should not be thrombolized. History of recent trauma, or patient who has the uncontrolled blood pressure like systolic more than 180 or the diastolic more than 110. So this patient should not be thrombolized. So all these are the precautions before giving the thrombolysis. But if especially in Pune, if we have the access to the many cath labs, and most of these cath labs are working 24/7. But when the patient is at the suburb or patient cannot be transferred or the cath lab is not available, then thrombolytic is a best reperfusion therapy for such patient. So thank you very much. Thank you, Hriday Sparsh. Thank you, IMA, for giving me this opportunity. Thank you very much.
Thank you, Umberto, sir, for a very excellent and lucid presentation. Because of constraint of time, we'll go for the next speaker. Question and answers we'll take afterwards. There are question and answers session also. We'll wait for that. And as you said, time is muscle.
Yeah.
And time is money. So we'll go further for the next lecture delivered by Dr. Krishna Dhoot. He'll speak on recent advances in management of antiplatelet post-angioplasty. So I request Dr. Krishna Dhoot, sir, to give a startup. Sir is MBBS from JN Medical College, Belgaum, Rajiv Gandhi University of Health Science, Bangalore. DNB from Balabhai Nanavati Hospital, Mumbai. DNB Cardiology, Narayana Hrudayalaya, Bangalore. Sir has an experience since 2011, Senior Registrar in Department of Cardiology, Narayana Hrudayalaya from Bangalore. He is a panel consultant in various hospitals, Ruby Hall Clinic, Sahyadri Specialty, Hadapsar, Deccan, Noble Hospital, Inamdar Multi-Speciality, Global Hospital. He was working with Dr. Shri Shiramat as Associate Cardiologist from January 2011. Have performed about 20,000 coronary angiographies and more than 5,000 angioplasties. Specialized in primary angioplasty, radial angiography, and angioplasties. Apart from coronary interventions, also performs peripheral angioplasties, permanent pacemaker implantation, balloon mitral valvoplasty, ASD and PDA device closure, certificate course in rotablation. So I request Dr. Krishna Dhoot to take over. Thank you, sir.
Thank you, Dr. Rajan Sancheti. Firstly, I would like to thank IMA committee members on behalf of Hriday Sparsh Heart Care team for giving us an opportunity. Dr. Sachin Yadav sir has explained in detail about the primary management of an acute coronary syndrome that include the unstable angina, non-ST elevated MI, and ST elevated MI. He has explained in detail about the reperfusion therapy, which will be fibrinolytic therapy or a primary intervention. So once the acute phase is over, the next main treatment of an acute coronary syndrome is antiplatelet. Antiplatelet therapy represent the mainstay of pharmacological treatment and secondary prevention of coronary artery disease. Dual antiplatelet, that is the combination of aspirin along with P2Y12 inhibitor, has been consistently shown to reduce the major adverse cardiovascular effect in a patient with acute coronary syndrome or a patient who undergoing the primary angioplasty. So today we will discuss about the role of ADP P2Y2 receptor in platelet adhesion and aggregation, and what are the P2Y2 receptor antagonists. The first reversible P2Y2 inhibitor, ticagrelor. What are the current guidelines for P2Y2 inhibitor or a dual antiplatelet therapy, and What are the future perspectives of antiplatelets? As we know, ADP is very important factor for platelet aggregation and thrombogenesis. ADP is basically stored in platelet and it releases on platelet adhesions to the injured endothelium of the vessel. Then ADP bind to P2Y2 receptor and stimulate the GP2B3A inhibitor receptors, and this GP2B3A receptor causes degranulations of platelet, releases thromboxane, and causes more adherence of platelet and more aggregation of platelet. So inhibition of these P2Y2 receptor can reduce the platelet activation and aggregation, and they prevent the thrombus formations and propagations and prevent the blockages of artery. We know P2Y2 inhibitor can work on two different sites. One is on the ADP binding, that is clopidogrel and prasugrel, and second is on the receptor, that is ticagrelor. So this chart shows whenever there is a damage to the endothelium, this platelet will attaches to the underlying tissue factors or von Willebrand factors and causes activation of the platelet. And this activated platelet causes releases of ADP, thromboxane A2, and this ADP attaches to the P2Y2 receptor and causes activation of GP2B3A inhibitor, and that causes degranulation of platelet and more adherence and aggregation of platelet, resulting into the thrombin formation. So what are the classical irreversible P2Y2 receptor antagonists? As we all first P2Y2 inhibitors was introduced in 1991, that is ticlopidine, but this drug was withdrawal due to its hematological adverse effect. Then in 1998, the first conventional DAPT drug clopidogrel was introduced, and it is used since last 20 years, and still we are using, and it is one of the most commonly used antiplatelet drugs. But because of some lack of pharmacological activity of clopidogrel, we needed a more powerful antiplatelet drugs, and the prasugrel was introduced in 2009. Then the first irreversible inhibitor ticagrelor, which are using which is more commonly used recently, is introduced in 2011, and the only IV drug is cangrelor. So there are a lot of study has happened in last 20 years about the antiplatelet. There are a lot of trials has happened with clopidogrel, mainly is CURE trial, COMMIT trial, or CLARITY trials. And there are trials which has happened for prasugrel is Triton-TIMI 13, Triton-TIMI, and then for the ticagrelor, there are multiple trials, and still there are a lot of trials are going on. So despite of proven clinical efficacy of clopidogrel, the pharmacological, we know that clopidogrel as a dual antiplatelet reduces the cardiovascular events over aspirin alone. So when we use an aspirin alone, the cardiovascular event rate was 11.4% as compared to 9.3% with a clopidogrel when combined with aspirin. Despite of its proven efficacy, still the clopidogrel is not an ideal antiplatelet drug because of its limitations. What are the limitations? Clopidogrel is a prodrug. It requires a 2 hepatic metabolisms before become an active metabolites, and around 85% of this drug will be inactivated before absorption. So only 16% of patients achieve 70% of inhibitory platelet activity by 2 hours. And second important thing is high variability response within the population. That is 25 to 30% of patients have a very low level of platelet inhibition. This is commonly seen patients which has a mutation of CYP2C19 allele. Because it binds irreversible with platelets, its offset of action is also slow. And if patient's coronary anatomy is not suitable for an intervention, and if patient has to be shifted for coronary bypass surgery, the bleeding risk are comparatively higher with clopidogrel. So to overcome these limitations, the next third generation antiplatelet was prasugrel. It is also a prodrug, irreversibly and non-competitively inhibit the P2Y2 receptor. Prasugrel mediate inhibition of platelet aggregation is approximately 5 to 9 times more potent than that of clopidogrel. Its absorption is more than 79%, and the peak plasma concentrations reaches by 30 minutes. So if you see, the clopidogrel has to undergo two steps metabolism before it's become an active metabolite, while the prasugrel will be before absorption. After absorption, it goes into intermediate metabolism, which by single steps convert into the active metabolites. And for ticagrelor, we don't require an enzymatic conversion. So in Triton TIMI 38, which was a major trial which compared the clopidogrel versus prasugrel, it has shown that the patient who has received clopidogrel along with aspirin has a primary endpoint, that is cardiovascular events, is around 12.1% as compared to the prasugrel with aspirin has a 9.9%. There is a significant reduction in the ischemic event in a patient who has received prasugrel. Specifically, the myocardial infarction and stent thrombosis has reduced significantly, but at the cost of increased bleeding risk. The bleeding risk with prasugrel was 2.4% as compared to 1.4% with clopidogrel. So this shows that there is increase in significant bleeding in 3 patients out of 1,000 patients who received prasugrel. So this uh, had made that in 3 subgroup of patients we cannot use the prasugrel. One is patient who has a transient ischemic attack or a stroke previously. The second, whose weight is less than 60 kg, and third is age group more than 75 years, who are more prone for developing the bleeding risk. Then chem is ticagrelor. It is a first reversible P2Y2 inhibitor. It is not a product. It does not require a metabolic activations. It is rapid onset of action and greater inhibitions of platelet aggregations than clopidogrel. It is reversibly bound, so it is faster reversal of effect than clopidogrel if it is stopped in case of bleeding. So ticagrelor absorption does not affect with food. Its bioavailability is 36%, 99% it is plasma protein bound, metabolized by the CYP3A4 active metabolite produced. Primary route of elimination is hepatic, and its half-life is 7 to 9. So if you compare these 3 antiplatelet drugs, P2Y2 blocker, the ticagrelor is the only drug which has a reversible inhibition of P2Y12 receptor. Clopidogrel and prasugrel both are prodrugs. Ticagrelor is not a prodrug. The important is mean inhibitory platelet activity, which is at 30 minutes, we see only 8% of patients in clopidogrel, around 31% of inhibitory platelet activity in prasugrel, and the 41% in ticagrelor. And the peak in mean inhibitory platelet activity at 2 hours is around 89% in ticagrelor versus 38%. And the variability with CYP2C19 is seen only with clopidogrel, not with prasugrel and ticagrelor. This makes these drugs more potent and more reliable. So if you see this, Garbanti et al. Has clearly explained that ticagrelor, when used with a loading dose, its inhibitory platelet activity within half hour reaches by 41%, and by 2 hours it is 88%, while that of clopidogrel it is just 8% and 38%. And if you compare for 24 hour also, the ticagrelor is much superior for inhibiting platelet activation. So we know faster onset of action, but it has a faster offset of action as compared to clopidogrel. For first 24 to 48 hours, the inhibitory platelet activity will remain same both in clopidogrel and ticagrelor. But after 48 hours, there is a significant decreases in inhibitory platelet activity in ticagrelor patients, which help us to send the patients for early surgery. So we know that we don't have a no genetical variation or non-responders in a ticagrelor, while in clopidogrel around 25 to 30% patients are non-responders. So when there is a switch happens after 15 days, the ticagrelor activity will remain same, while that clopidogrel activity varies. So it is more potent and more reliable than the clopidogrel. So we know that ticagrelor is a more potent, but still the study has been conducted by in a plateau. We show compare the ticagrelor versus clopidogrel. Around 18,000 patients were enrolled in this study. Clopidogrel was given 300 to 600 milligram of loading dose followed by 75 milligram OD maintenance dose, while ticagrelor 180 milligram of loading dose and 90 milligram of maintenance dose. The primary endpoint was composite cardiovascular death, EMI, or a stroke, and secondary endpoint was individual cardiovascular death, EMI, stroke in patients intended for invasive management. Then primary safety is the major bleeding. And in this study, it has shown that there is a 16% cardiovascular risk reduction with the ticagrelor. So ticagrelor with aspirin has a cumulative incidence that cardiovascular death, myocardial infarction, stroke in around 9.8%, while clopidogrel and aspirin has a 11.7%. And if you compare the bleeding risk was nearly similar between ticagrelor and clopidogrel, except in ticagrelor there are 2 to 3 cases has an increased major bleeding as compared to clopidogrel. So in this study, it has shown that dyspnea was reported more frequently in a patients on ticagrelor than clopidogrel. We have seen around 13.8% patients in ticagrelor versus 7.8% in clopidogrel. But most of these episodes lasted less than a week. Ticagrelor associated dyspnea was mostly mild to moderate and did not affect efficacy. 1 in 9 patients discontinued study drug because of dyspnea, that is around 0.9%. The higher frequency of dyspnea with the ticagrelor was not associated with any detectable detrimental effect on the lung functions compared to clopidogrel. So how long we need to give a dual antiplatelet therapy? That is most of time a debatable question. But in a Pegasus STEMI 54 trial, where ticagrelor can be given after 1 year of post-MI patient. In this, they have 3 arms where ticagrelor 90 mg BD continued after 1 year. In the second arm, ticagrelor 60 mg BD was given, and third arm was placebo. The primary endpoint was same, the cardiovascular death, MI, or stroke, and the median follow-up was 33 months. In this study, it has shown that the ticagrelor, if it is continued beyond 1 year, the cardiovascular event in post-MI patients was significantly less. But if you continue with the 90 milligram or 60 milligram, there is no difference in the efficacy of the drug after 1 year. But the bleeding risk was comparatively higher with the ticagrelor 90 than the ticagrelor 60 mg BID. So role of ticagrelor in STEMI patients along with fibrinolysis. In a TREAT trial where there there was around 4,000 patients less than 75 years of age receiving fibrinolysis therapy has received ticagrelor or clopidogrel, and the follow-up was 12 months. There was no difference in both drug in efficacy or safety. Ticagrelor is as good as clopidogrel in STEMI patients undergoing fibrinolysis. But still, we need a larger study to say that ticagrelor can be given along with a fibrinolytic therapy. So what are the current guidelines for P2Y2 inhibitor? How long we should continue? We need to decide depending upon the risk score. There are the two risk score. One is precise DAPT score and second is DAPT score. This precise DAPT score will calculate the bleeding risk at the time of coronary stenting. So we can decide that we need to give the DAPT for short term, that is 3 to 6 months, or for a longer duration, that is standard for 1 year. These 5 factors we need to monitor is hemoglobin. Lower the hemoglobin, the risk of bleeding is high. WBC count, if the higher the WBC count, again the risk of bleeding is high. Age, more than 75, risk of bleeding is high. Creatinine clearance less than 30, the risk of bleeding is high. And is there any prior history of bleeding? So this score is between 0 to 100. If the score is more than 25, these patients are more risk for bleeding. We need a shorter DAPT for 3 to 6 months. If score is less than 25, we can give a standard DAPT. Once we have decided the standard DAPT, then at 1 year, we need again to evaluate the ischemic risk versus the bleeding risk, which can be done by the DAPT score. It has a 9 parameters. One is age, history of cigarette smoking, diabetes, MI at presentation, or prior PCI or prior MI. If patient is on paclitaxel eluting stent, or stent diameter is less than 3 millimeters, or patient is in congestive heart failure, or his ejection fraction is less than 30, or if he has undergone CABG, he is having vein grafts or not, or vein graft stenting. So the score is between -2 to 10. If score is more than 2, these patients are high risk for ischemic event, and these patients requires a longer DAPT, that is for more than 1 year to 30 months. If score is less than 2, then we need to go for standard DAPT, that is for 1 year. So ESC recommendation for DAPT basically same on the risk score. If patient is going for PCI, if he has an acute coronary syndrome and he's receiving a drug-eluting stent or drug-coated balloon, then we need to see for the high bleeding risk. If there is high bleeding risk, we need to continue DAPT with clopidogrel or ticagrelor for 6 months. If there is no high risk bleeding, then we can use a prasugrel or ticagrelor for 1 year, and then aspirin with ticagrelor for more than 12 months. In a patient with a stable coronary artery disease, again undergone angioplasty with drug-coated stent or drug-coated balloon, if he is having a high bleeding risk, then antiplatelet with clopidogrel for 1 month. If there is no high bleeding risk, then with antiplatelet along with aspirin and clopidogrel for 6 months. And again reassess. If the bleeding risk is less, we can continue antiplatelet for dual antiplatelet for more than 6 months. If patient is going for a medical management, again ACS with high bleeding risk, there is no high bleeding risk, then you can give dual antiplatelet aspirin and ticagrelor or aspirin and clopidogrel for 1 year, assess, and we can continue beyond 1 year. If there is a high bleeding risk, then clopidogrel or ticagrelor for 6 months. So ESC guideline has recommended a switching from clopidogrel to ticagrelor. So many times we see that patients has been loaded in casualty with clopidogrel. They come to cath lab and we find that there is a significant lesion which need to be stented with a high thrombus load. We want a more potent antiplatelet drugs. So we want to give a ticagrelor. So patient is already loaded with clopidogrel. So how much ticagrelor we have to give? We need to give the full dose of ticagrelor and continue the BD dose later on. So in patient with SCS who was previously exposed to clopidogrel, switching from clopidogrel to ticagrelor is recommended early after hospital admission at a loading dose of 180 milligrams, irrespective of timing and loading dose of clopidogrel. So once we know how long we should give the antiplatelet drug, especially the dual antiplatelet therapy. But recently, there is a lot of development happen in the stent size, strut thickness, and because of these potent antiplatelet therapy, should we continue dual antiplatelet beyond 1 year, or we need to change our policy? The aspirin, which till now we are considering the backbone of antiplatelet therapy, can we stop the aspirin after 3 months? So this was a recent trial, Twilight trial, where ticagrelor monotherapy after shorter duration of DAPT was continued and compared with ticagrelor plus aspirin. The objective is to determine the impact of single antiplatelet therapy, that is ticagrelor monotherapy, versus dual antiplatelet therapy, that is ticagrelor plus aspirin, for a 12 months in reducing the clinically relevant bleeding among high-risk patients who have undergone successful PCR. The second objective is, in similar study, was to see the ischemic adverse event among high-risk patients who have undergone successful PCR. So in this study, around 9,000 patients were enrolled. This patient has received for 3 months both aspirin and ticagrelor, and after 3 months, the one group has received ticagrelor plus aspirin, and second group has received 1G ticagrelor with placebo, and then the study compared between these two drugs. These are all high-risk angioplasties. The thrombus load was significantly high, or the patient has a calcific vessels or bifurcation lesion. The stent size was also nearly 40 millimeter in most of the patients. And the study has shown that 44% lower risk of bleeding with the ticagrelor monotherapy as compared to the ticagrelor plus aspirin. So the rate of bleeding was around 7.1% in ticagrelor plus aspirin as compared to 4% with ticagrelor. But there is no difference in the efficacy between these two groups. So as per Twilight study, in a high-risk patient who is undergoing PCI and we need to continue the 3-month dual antiplatelet therapy and then followed by monotherapy. It has a better safety from bleeding point of view versus the dual antiplatelet therapy with aspirin plus ticagrelor, with equal efficacy for ischemic event. So the take-home messages are: P2Y2 receptor antagonists are essential part of DAPT for secondary prevention in post-MI or revascularized patients. DAPT with aspirin plus P2Y2 receptor antagonist can be used up to 30 months of optimal CV risk reduction in selected group of patients. We need to balance between the risk of bleeding versus the risk of ischemia. Ticagrelor is the latest oral P2Y2 receptor antagonist which provide faster reversible platelet inhibition. Ticagrelor based DAPT reduces cardiovascular event, mortality and stent thrombosis versus clopidogrel based DAPT in ACS. Current guidelines provide preference to ticagrelor over clopidogrel for DAPT, and in future, ticagrelor monotherapy may be approved for a patient with a high bleeding risk after 3 months of uneventful DAPT. Thank you.
Thank you, Dr. Kishore. It is a very informative presentation.
Thank you, sir.
Thank you.
For very excellent presentation. Madam
Aarti madam and Sanchayji sir, there is one question in chat box related to this presentation.
Yeah.
I'll introduce Dr. Modgi Akash Vishwanath. His next talk would be on Novak in management of deep vein thrombosis, that is DVT.
Sir,
Okay.
the question is to Dr. Dhut sir. If a patient is persistently complaining of dyspnea on ticagrelor, would you be tempted to change the ticagrelor? And are bradycardia and dyspnea limiting factor to use ticagrelor?
Yeah, I already explained. Dyspnea is seen in around 13% of patients with ticagrelor. But if you continue it for 1 to 2 weeks, the dyspnea, most of the patient will subside. But around 1% of patient need to be discontinued because of the dyspnea. And when we are discontinuing, we need to load with clopidogrel, full dose of clopidogrel, and then continue with BD dose. The bradycardia is known with the clopidogrel, but they are not very significant, and we need not to stop the ticagrelor for this bradycardia. We need to monitor these patients.
Dr. Modgi Akash, sir is MD from Vijay Medical College and Sassoon General Hospital, DNB Cardiology, Ruby Hall Clinic, lecturer in Department of Medicine, presently working in Ruby Healthcare Services, Pimpri, panel consultant in Ruby Hall, Sahyadri Hospital, and all the Sahyadri group of hospitals. So I request Dr. Modgi sir to continue his talk on Novak in management of deep vein thrombosis, that is DVT, and pulmonary embolism. Sometimes the patient goes in shock. So I request Dr. Modgi Akash sir to take over.
Yeah. Thank you, sir.
Modgi
Thank you,
sir.
Sanjit sir. Thank you, Aarti Nimkar ma'am and IMA for allowing giving me the topic for the presentation. So today's topic of presentation is newer oral anticoagulants in management of DVT and venous thromboembolism. After the two lectures on coronary artery disease, we are moving towards a different cardiovascular disease as a DVT and venous thromboembolism. And this being a COVID pandemic, in fact, we are going to face many post-thrombotic complications related to COVID. Patients are going to present to us with DVT and venous thromboembolism. Also, many of us are treating the patients of DVT, especially the surgeons, orthopedicians, gynecologists. So, from the earlier management, where we used to use heparin, warfarin, we are moving towards the newer therapy in the form of oral anticoagulants, which are direct acting antithrombotics. So we are going to see, are we really in a position, or we have got the enough evidences to replace the traditional management of heparin and warfarin with those of newer oral anticoagulants. So first we should look after what exactly is the DVT venous thromboembolism. This is the third most frequent cardiovascular disease with annual incidence between 75 and 270 cases per 1 lakh inhabitants. And with a subsequent decade after age of the 40, the risk of DVT and venous thromboembolism increases or is doubles. While the pulmonary embolism is the most serious presentation of venous thromboembolism or DVT, with 1 and 3 month mortality rates between 9% and 11%. And if you see the risk factor, it revolves around the Virchow's triad. What the Virchow's triad states that DVT is responsible because of stresses in the vessel, vessel wall injury, and hypercoagulability. So whatever the risk factors are there, it revolves around this Virchow's triad. So DVT can be differentiated between two, whether it is a provoked or unprovoked. Provoked venous thromboembolism is seen in the presence of temporary or reversible risk factor. For example, patient has undergone a trauma, he has undergone a surgery, patient is immobilized for a long time, or patient is traveling in an airplane for more than 24 hours, he is immobilized in the airplane, pregnancy. These are the provoked venous thromboembolism. While unprovoked these are the absence of the risk factor, which are called as the unprovoked type of the DVT. So the treatment also depends upon this differentiation between provoked venous thromboembolism and unprovoked. So what are the goals of the venous thromboembolism treatment? So it can be divided into two. One is the initial treatment when the patient when the patient acutely presents with DVT while the long-term prevention. And the initial treatment consists of the stopping the propagation of the acute clot which has formed, to prevent the embolism, to protect the pulmonary circulation, and to restore the venous return. While the long-term prevention, when the acute treatment has been given, and the long-term treatment for the DVT requires for the prevention of recurrent venous thromboembolism, post-thrombotic syndrome, and if there is no significant dissolution of the clot in the pulmonary vasculature, it may lead to chronic thromboembolic pulmonary hypertension. So our goal for long-term prevention is to prevent the recurrent venous thromboembolism and post-thrombotic syndrome and CTEPH. And of course, the goal of the UHT is to minimum bleeding risk. So what are the newer concepts in anticoagulation therapy? As I told you earlier, earlier the conventional therapy was to use the heparin along with vitamin K antagonist. But nowadays, we have been switching towards the single dose therapy because of the advent of the newer oral anticoagulants. With the newer trials which are coming up, we are giving us the evidences to use the newer therapy in the form of newer oral anticoagulants. And the therapy also should be individualized. It depends upon the clinical setting, whether the patient has undergone the surgery, whether the patient patient is pregnant, or whether the thrombosis is seen in the setting of post-surgery, post-traumatic, or in the orthopedic setting, which depends upon the patient characteristics, whether the patient has any underlying renal disease, or patient is pregnancy, or patient is pregnant, and depends upon the individual prognosis. So how do you classify the lower limb DVT? Even after the classification of the lower limb DVT, the treatment also depends upon the deep vein thrombosis where we see it. For example, in the proximal DVT, which is involving the popliteal vein, femoral, deep femoral, common femoral, iliac vein. In such kind of the treatment should be started early with anticoagulants. Aggressive parenteral therapy in the form of heparin or LMWS should be given. But in case of distal DVT, which consists of involvement of the gastrocnemius vein, tibial, soleus, or peroneal. In such kind of DVT, we can go in the form of conservative treatment. While the superficial vein thrombosis, which involves the great stiffness, in fact, the prophylactic treatment is sufficient for such kind of patients. So what are the clinical triggers? The DVT can be divided into unprovoked and provoked. In unprovoked, if no any causes, if we don't find any cause for the deep vein thrombosis, these are usually classified into unprovoked, while the provoked, in the cases where there is definitive trigger for the DVT in the form of immobilization, surgery, or trauma. So such kind of DVTs are called as provoked. The treatment also depends upon the classification of provoked or unprovoked. If the patient has DVT which is unprovoked, the long-term treatment is usually advisable, which is more than 3 to 6 months. While for the provoked, we can give just short-term treatment for the 3 to 6 months, and then depending on the patient's condition, we can stop the anticoagulants. So what are the targets of anticoagulants? If you see the earlier therapy, which was vitamin K antagonist, it inhibits the synthesis of factor 2, 7, 9, and 10. While the newer anticoagulants, these are factor 10A inhibitors. For example, they inhibit the factor 10A like apixaban, endoxaban, rivaroxaban, and fondaparinux. While the direct thrombin inhibitors, these are dabigatran, bivalirudin, irurin, and ergotroban, which prevents the conversion of fibrinogen, fibrin, and then fibrin factors of formation are prevented. So what are the criteria or what are the settings in which we can replace the current agents? If for the treatment of DVT at present, the oral liver anticoagulants are advised for the treatment of DVT, pulmonary embolism, in case of non-valvular atrial fibrillation and hospitalized medically ill patients. So we are going to see all the trials which are really supporting for the use of oral anticoagulants for the treatment of DVT and hospitalized medically ill patient. We are not going to see regarding the non-valvular atrial fibrillation. Do we really have the evidence to switch from the traditional treatment of heparin, warfarin to the oral anticoagulants? So the treatment of venous thromboembolism, the traditional treatment consists of unfractionated heparin, LMWH, which bridges to start of warfarin. So this is a study which has compared dabigatran with that of warfarin in the treatment of acute venous thromboembolism. In this study, dabigatran was used 150 mg BD for 6 months. It is a double-blind, double-dummy, non-inferiority study as compared to the warfarin. So this is the result of the RECOVER study. In the efficacy was compared of dabigatran along with the warfarin. Efficacy was compared in the form of recurrent venous thromboembolism or fatal recurrent venous thromboembolism. If you see the evidence, dabigatran has found only two patients who were in the group of dabigatran, the recurrent venous thromboembolism incidence was only 2.4% as compared to warfarin, which had 2.1%. So it is not much of a difference in it. And if you see the major bleeding complication, in fact, 20 patients in the dabigatran group had major bleeding, while compared to the warfarin, it had 24 patients of the warfarin group had major bleeding. In fact, the bleeding risk in the dabigatran group is much less as compared to the warfarin group. But there is a limitation to this RECOVER study. In this RECOVER study, in fact, the patient had received initial parenteral anticoagulation in the form of heparin for 9 days. And there is no data to support the use of dabigatran monotherapy for acute venous thromboembolism. Even at present, if you are going to use dabigatran, the patient has to be given some parenteral anticoagulants before the start of dabigatran. This is another study, which is the Einstein's DVT study, which has compared the oral rivaroxaban for symptomatic venous thromboembolism. In this study, rivaroxaban was used for 50 milligram orally twice a day for 3 weeks, and then 20 milligram OD for 3 months. And for enoxaparin was given in another group with bridge to warfarin for 2 to 3 months, and with the INR K between 2 to 3. It is an open label and non-inferiority trial. Even if you consider this trial, the rivaroxaban group, the efficacy study which was seen in the acute DVT study, the efficacy for which is compared with warfarin and rivaroxaban in the form of recurrent venous thromboembolism. The incidence of recurrent venous thromboembolism in the rivaroxaban group was 2.1 as compared to enoxaparin, which is 3%. So in fact, rivaroxaban is found to be more efficacious as compared to that of enoxaparin. And regarding the bleeding risk, it has been found to be much more safer or comparably safer to that of enoxaparin. The bleeding was seen, major bleeding or the clinically relevant major bleeding was seen in 8.1% of rivaroxaban, even similar to that of enoxaparin, which was seen in 8.1% of the patients in the enoxaparin group. This is another trial which has compared rivaroxaban with that of heparin in the case of symptomatic pulmonary embolism. Patients having pulmonary embolism, they were grouped into 2 groups. One group received rivaroxaban 50 milligram BD for 3 weeks, then 20 milligram OD, followed then in another group they received enoxaparin 1 milligram per kilogram twice a day with bridge to warfarin with INR kept between 2 to 3. It is open label non-inferiority trial. Even in this trial, the efficacy was compared with the recurrent venous thromboembolism episodes in both the group. In fact, rivaroxaban group had 2.1% and 1.8% in case of standard therapy. There's not much of a difference. It is non-inferior. And if you see the anatomical extent in both the group, rivaroxaban as well as in cases of in case of standard therapy, almost 309 and 290 patients were seen in which had limited vasculature of single lobe involvement in pulmonary embolism, while the extensive multiple lobe or more than 25% interpulmonary vasculature was seen in almost 600 patients of both the groups. So even in such cases, the pulmonary embolism, recurrent pulmonary embolism in rivaroxaban group was much lesser as compared to the standard therapy. The major bleeding, in fact, was much lesser in case of rivaroxaban group, which was 1.1%, while in the standard therapy it was around 2.2%. This is another trial which compared against the rivaroxaban for symptomatic venous thromboembolism. This is the Einstein trial. It compared the rivaroxaban in one group with that of enoxaparin and warfarin in the another group. This is again a non-inferiority trial. In this the same study, they compared with the extended treatment of rivaroxaban when the patients have undergone the treatment acutely for DVT for 3, 6, or 12 months, and later on, if the patient is an unprovoked group which requires long-term therapy with rivaroxaban, they compared the 2 groups. In one group, they gave rivaroxaban 20 milligram OD, while in the another group, they gave the placebo drug for 6 to 12 months after the patients had completed the acute treatment. If you see the recurrent venous thromboembolism in the group which received rivaroxaban, it is just 1.3% with the major bleeding of just 0.7%. While in cases of the placebo group, the recurrent venous thromboembolism was 7.1% as compared to 0% in major bleeding. Because this is the placebo drug, the risk of bleeding was very less. But if you see the efficacy of the rivaroxaban in the patients who have received extended treatment after the acute treatment of DVT, the recurrence of venous thromboembolism reduced to just 1.3% as compared to the placebo group, which had 7.1%. This is another trial which compared the use of dabigatran and warfarin placebo in venous thromboembolism. Along in the same trial, this is the RESONATE trial in which the patient had completed the acute DVT treatment for 6 to 18 months, and then they were grouped into two groups. One group receiving dabigatran 150 mg BD, another group received placebo for 6 to 18 months. The recurrent venous thromboembolism in such patient reduced to just 0.4% with the major bleeding of 0.3%, while in the placebo group, the recurrent venous thromboembolism was 5.6% as compared to 0% of major bleeding. So the dabigatran has also been found to be effective for the long-term treatment in cases of extended treatment of DVT after acute treatment of venous thromboembolism. Even this is the same thing. This is the efficacy. This is the efficacy study in the cases of dabigatran and placebo. The recurrent venous thromboembolism reduced to 0.4%, while in the placebo group it was around 5.6%. And the bleeding in the case of dabigatran group was on the higher side, which was around 10.5% as compared to the placebo, which was around 5.9%. And the major clinical bleeding was a bit on the higher side. If you see the RESONANCE study, it is a dabigatran, so the primary endpoint of efficacy analysis. It is just seen in 3 number of the patients, while 37 patients from placebo group, they found to have recurrent or fatal venous thromboembolism, while the major bleeding was seen in 2 patients, while in the major bleeding was seen in just 0 patients. This is a trial which involved trial was done on apixaban for the extended treatment of venous thromboembolism. Patients were grouped into 2 groups. In the patient after the treatment of acute venous thromboembolism for 6 to 12 months, one group received apixaban 2.5 mg BD, another group received apixaban 5 mg BD, and third group for placebo for around 12 months. If you see the venous thromboembolism recurrence in the apixaban group, it was just 1.7% in both the groups, while the major bleeding was also not very much. It was around just 0.2% and 0.1% in both the groups, while in the placebo, the recurrent venous thromboembolism was around 8.8%, while it was just 0.5% of major bleeding in the placebo group. This is the graph. If you see the graph, the apixaban of 2.5 mg dose and 5 mg apixaban, which was in both the graph, shows around 1.7% of the efficacy endpoint, while in the placebo it was 8.8% of the efficacy endpoint. And the major clinical bleeding was much higher with 5 mg BD dose, which was used in the apixaban, was 4.3%, while it was 3.2% in 2.5 mg BD dose of apixaban, while it was 2.7% in the placebo group. This is another trial which compared the endoxaban in the treatment of venous thromboembolism. It is Hokusai venous thromboembolism trial. In this patient, both the patients of acute thromboembolism was grouped. They was divided into 2 groups. One group received standard therapy with LMWH plus warfarin, and another group it received low molecular heparin plus endoxaban. If you see, even in endoxaban, the low molecular heparin was used for 5 days. They compared the primary efficacy outcome in symptomatic recurrent venous thromboembolism or VT related death, while the safety outcome was discussed in the form of major or clinically relevant non-major bleeding during the treatment. There was the efficacy results. There was only 3.2% of the patients in endoxaban group had recurrent venous thromboembolism, while in the warfarin group had 3.5% of the recurrent venous thromboembolism, while the major bleeding was seen in 8.5% of the patients in endoxaban group, while the major bleeding or clinically relevant non-major bleeding was seen in 10.3% of the warfarin group. So this denotes the superiority of endoxaban as compared to the warfarin. So these are regarding the acute DVT and pulmonary embolism. But what about the trials? Are we in a position to start oral anticoagulants orally in patients of medically ill patients, those who are admitted in the ICU with other conditions? This is a trial comparing the rivaroxaban for thromboprophylaxis in acutely medically ill patients. This is a Magellan study. In this study, the control group received enoxaparin, while the patients of another group received rivaroxaban 10 milligram OD for 10 days. If you see the efficacy, it was just the efficacy of 2.7% was seen with rivaroxaban group, the patient, and then in the control group, it was also similar. While at the long term, if you see the venous thromboembolism incidence at 35 days from the start of the rivaroxaban as compared to the enoxaparin, it was seen in 4.4% of the patient, the recurrent venous thromboembolism rivaroxaban group as compared to 5.7% in the enoxaparin group. While the measured bleeding was 2.8% in rivaroxaban as compared to 1.2% in the enoxaparin group, and at 35 days it was 4.1% and 1.7% in the enoxaparin group. So the incidence of venous thromboembolism has reduced in the patients who have been given rivaroxaban at the expense of a slight increase in the measured bleeding. This is another trial. This is the ADAPT trial, which compared apixaban with enoxaparin for thromboprophylaxis in medically ill patients. So the patients were grouped into one group received apixaban 2.5 milligram BD and another group received enoxaparin. So after giving 2.5 milligram BD, the recurrence rate of venous thromboembolism episode was seen in just 1.73% of the patients who received apixaban as compared to the control group, which had incidence of 1.61% of venous thromboembolism. While at 30 days, it reduced in apixaban group of 2.71%, and it was seen in 3.06% of enoxaparin group. Even if you compare the major bleeding, it was seen just around 0.47% at 35 days in the apixaban group, while in the control group it was around 0.19%. Even the clinically relevant non-major bleeding at 35 days, it was 2.67% in apixaban group, while in the control group it was just 2.8%. So apixaban has found this study shows that the apixaban is really effective for the thromboprophylaxis in patients who are admitted in the ICUs. So what are the trials? These are the trials. STEM trial is compared in enoxaparin with the placebo. ADAPT trial compared apixaban with enoxaparin. Magellan trial compared rivaroxaban with enoxaparin. All these trials, they actually denote the decrease in the incidence of venous thromboembolism in these patients as compared to the previous standard therapy in the cases of extended venous thromboembolism prophylaxis in medically ill patients. So the net clinical benefit with the use of rivaroxaban, apixaban have been found to be much more superior as compared to that of heparin or warfarin in thromboprophylaxis in medically ill patients. At the slight increase in the major bleeding was seen in rivaroxaban, but the major bleeding, if compared with the apixaban, is not much. It is almost comparable bleeding. So what are these are the evidence in nutshell regarding all the oral anticoagulants, the dabigatran, rivaroxaban, apixaban, endoxaban. Only with dabigatran and endoxaban, they require the bridging with LMWH before start of dabigatran and endoxaban. But all the other drugs, for example, rivaroxaban, apixaban, they can be started orally without any parenteral heparin. This can be given for the treatment of venous thromboembolism and acutely, and the efficacy has been found to be comparable to that of the standard therapy with heparin and warfarin, with less number of bleeding risk. If you see the non-inferiority, all this dabigatran, rivaroxaban, apixaban, endoxaban found to be non-inferior to warfarin for the long-term therapy and the short-term therapy with newer oral anticoagulants. But the another thing to consider, these newer oral anticoagulants have not been compared with each other for their efficacy and the safety profile. They have been compared with warfarin. So they are found to be non-inferior to warfarin for the use in long-term of venous thromboembolism. So what exactly we started with initially with the low molecular heparin substitute for 3 to 5 days with with oral vitamin K antagonist, and then we switched over to dabigatran and endoxaban, which have been shown by the trials of Recover and Hokusai, which shows the LMWH subcut to be given for 5 to 6 days, followed by dabigatran 1 mg BD or endoxaban 60 mg OD, and then finally the single drug approach in case of DVT and pulmonary embolism, in which have been proved by the Einstein Amplify trial. Rivaroxaban can be given 50 mg BD for 3 weeks, followed by 20 mg OD, and then apixaban 10 mg BD for 7 days, then 5 mg BD in case of apixaban. So these are the trial actually which have shown the efficacy of the neuro-oral anticoagulants as compared to the warfarin, and we can shift our therapy from the earlier traditional treatment of low molecular heparin and warfarin to that of single drug approach. So this is another slide. We show the prophylaxis which we can give in the patients of knee replacement or the medically surgically ill patient. In case of dabigatran, it is 110 milligram 1 to 4 hours after the surgery and after hemostasis has been achieved on the first day. Then 220 milligram for 28 to 35 days. This is for the prophylaxis in the patients who are undergoing surgery or undergoing surgery or medically ill patients. And then for rivaroxaban for the knee replacement, it is 10 milligram daily for 12 days. For hip replacement, it is 10 milligram OD daily for 35 days. For medically ill patients, it is 10 milligram OD for 31 to 39 days, depending upon the scenario of the patient. So these are some guidelines regarding role of neuro-oral anticoagulants in venous thromboembolic treatment, which has been given by in the CHEST journal in 2016. In patients with proximal DVT or pulmonary embolism, the long-term therapy of anticoagulant therapy is required over no such therapy, which has grade 1B indication. In patients with DVT of the leg or pulmonary embolism and no cancer, as long-term first 3 months anticoagulant therapy, dabigatran, rivaroxaban, apixaban, and endoxaban is suggested over vitamin K antagonist. In patients with DVT of leg or pulmonary embolism and cancer, still the long-term treatment at present in this kind of scenario is low molecular heparin over vitamin K antagonist or dabigatran, rivaroxaban. In patients with DVT of the leg or pulmonary embolism who received extended therapy, then there is no need to change the choice of anticoagulant after first 3 months. In patients with proximal DVT of the leg or pulmonary embolism provoked by surgery, the anticoagulation for the 3 months is required for a shorter period, or treatment for a longer time limited time period for 6 to 12 months, depending upon the scenario, or extended therapy if there is no cause for the DVT has been found. So what are the key messages? The paradigm of DVT treatment is rapidly changing. The evidence for NOAC is strong enough to spread the use of these drugs instead of vitamin K antagonists. A single drug approach is very attractive and very useful for an outpatient management of patients with DVT. More data is needed in patients with massive pulmonary embolism. After lytics, we even don't have the evidence regarding that. Extended treatment is the rule for unprovoked DVT pulmonary embolism, but no firm recommendation about when to stop. Thank you. So at present, we have got much more evidence so that we can shift from the traditional therapy to that of neuro-oral anticoagulants, and even few of the patients of pulmonary embolism, if they are stable, of DVT, if they are stable, we can manage it on the outpatient department by giving the single dose oral therapy like rivaroxaban. Thank you.
Thank you very much, sir, for this academic feast, I would say. Beautiful presentation. And there is one question.
Sir, there are a lot many of questions.
Okay.
And
you can take it last.
Time limit, so we'll take 2-3 questions from this subset, and then at the end we'll take the rest of the question.
Okay.
Sir, Akash, sir, there is question for you. NOAC, any NOAC in CVST and valvular AF?
Any NOACs
in CVST and valvular AF?
At present, valvular AF only into mild to moderate valvular AF NOACs can be used, but for significant valvular AF, for example, severe mitral stenosis or severe valvular aortic stenosis, is still not yet recommended. It is still the warfarin.
A role of NOAC and anticoagulant in chronic portal vein thrombosis. There is one more question. NOAC and anticoagulation in chronic portal vein thrombosis. No, there are few studies for even for the NOVAX. with the rivaroxaban, but there are not extensively studied as DVT and
DVT and pulmonary embolism.
So there is one more question. Please, can you talk about the catheter-directed thrombolysis in DVT, VT, and can conventional IV thrombolysis be used in DVT, VT?
If the patient is very much unstable, actually we are using the catheter-directed thrombolysis. But if stable patient is around BP is around 90, 100, we are using the conventional IV thrombolytics for that as well. Only in the cases where the patient is very much unstable, if the bleeding risk is very high, we are using the catheter-directed thrombolysis. Otherwise, conventional intravenous thrombolytics we are using it routinely if the patient has hypotension in case of pulmonary embolism and DVT.
There is one more question. I think we should take this as a final for this session. When should, Dr. Darira has asked, when should thrombophilia workup be sent in thromboembolism? In which cases? Any bare minimum workup considering cost issue?
If there is no any risk factor found, if the patient has DVT, if it is unprovoked, after initial treatment, when we stop the initial treatment, then the patient should be investigated for DVT. And if the patient is a female, then factor V Leiden and APLA study should be done. For a patient is non-female, then we can go for antithrombin 3. The thrombophilia workup should be done in all the cases. There is no any bare minimum which is required. I think antithrombin 3, APLA, then ANA, then factor V. These things should be done in patients of unprovoked DVT.
So if you go for the individual workup, that will cost more rather than giving the thrombophilia workup, which will be costing around 7,000-8,000. If you do individual test, it goes around 15,000. So
exactly,
to do it as a thrombophilia workup, which can be done at a minimum bare cost of for this workup.
But especially if the patient is female, then we should look for the factor V.
Factor V.
Thank you very much, sir, for elaborate explanation. Can we go for next lecture?
Sir, yes, but sir.
Okay. So next, Dr. Omkar Thopte, he will speak on COVID-19 and MI, cardiologist view and experience. I would say very good topic. Sir is fellow interventional cardiology from Rajiv Gandhi University of Health Science, Bangalore. During fellowship under exchange program with Cleveland Clinic, Ohio, in USA, got training for critical interventional procedures like TAVI, Mitra clips, complex coronary interventions. Then he has a heartbeat clinic at Katras. He is empaneled at Ruby Hall Clinic, Sayadri Hospital, Global Hospital, and Noble Hospital. Sir, please take over. Dr. Omkar Thopte.
Yeah, very good afternoon, everybody. I would like to thank IMA and Hriday Sparsh Clinic team for giving me opportunity to present. Actually, Dr. Sachin Yadav sir already had elaborated over myocardial infarction so extensively, but I would like to present acute myocardial infarction in this COVID-19 pandemic area as a cardiologist perspective. As we all know, since last March 2020, the pandemic of COVID-19 had started in India. The patients with the cardiovascular risk factors and established cardiovascular disease represents the vulnerable population when suffering from the COVID-19. Actually, after this pandemic, lockdown was declared, and what we came across in India and across world, that there is a sharp decline in cases of acute coronary syndrome. So in Australia, the admissions of acute coronary syndromes are decreased by 39.4%. And similarly, it was seen in Italy also. We have data from Spain also. There is a significant reduction in activity of interventional cardiologists during this COVID-19 pandemic. Number of diagnostic procedures were decreased by around 50%. Also, the percutaneous coronary interventions also decreased by around approximate 50%. Structural interventions like devices which we put, those are decreased by around approximately 80%. And also the PCI in STEMI patients were decreased by 40%. So drastically the patients with ACS coming to the hospitals, they decreased in Spain, Australia, Italy, globally overall. And 5% of interventional cardiologists got this COVID-19 infection while treating patients. What is scenario in India? There is a multicentric study which was carried in southern India, mainly involving Tamil Nadu state. They have seen the acute myocardial infarction cases are decreased so drastically, and they came out with the factors which caused the decrease in ACS patients. Mainly the unwillingness of a group of patients to visit hospital due to fear of COVID-19 getting that infection while going to the hospitals. Then reduced noise and air pollution, which is one of the risk factor for AMI. Reduction in occupational stress. Everybody was staying at home and they were doing all the jobs from home itself. Then avoidance of travel while going to the job, coming back. Then there is decreased exposure to the tobacco smoke or alcohol. Alcohol was not available during lockdown. Pollution has decreased. People were not getting junk food also. Then adherence to the relaxation and recreational activities via audio-visual means. Then integration with the family members. People were expending their most of the time at home. They were engaged with the activities of their interest, like reading books and sports. Long hours of sleep, practicing exercise, yoga, meditation. Everything has reduced the stress of the person. Then limiting to the homemade food. They were not getting that junk food which was freely available before this COVID pandemic. Then adoption to the healthy lifestyle, and overall less physical and mental strain were the main factors. Basically, this study they have done during the early lockdown phase, and they compared the values which were there in 2019 April and in 2018 April. So there is a 50% reduction in acute myocardial infarction cases which were presenting to the hospitals and the clinics. Now coming to the pathophysiology of COVID infection and with the coronary or the cardiovascular diseases. Though there is a sharp decline in acute myocardial infarction cases, one thing is there: if the patient gets that COVID-19 infection, in those subset, the cardiovascular death or cardiovascular risk goes much, much, much higher. Why is it so? We all know the COVID-19, this coronavirus binds to the ACE2 receptor, which are angiotensin receptor 2, which are present over the cells, and they get entry into the cell. These ACE2 receptors are present on lung, heart, and the blood vessels, also on gastrointestinal tract also. What they does, after coming inside the cell, they causes the endothelial cells to dysfunction, which are present on microvessels, small caliber vessels, and the macro vessels, the big caliber vessels. Due to this endothelial dysfunction in the micro vessels, it causes basically no flow, reflow phenomenon in patients with myocardial infarction. While in the big vessels like coronaries or the cerebral arteries, it causes instantaneous instability in the plaque, which causes the rupture of the plaque followed by the event. like a acute coronary syndrome or the stroke. Also, this COVID coronavirus, what it does, it causes immune activation and inflammation, which causes release of cytokines like interleukin 6, interleukin 7, interleukin 22, which causes instability in a plaque, which may lead to the rupture of the plaque and acute coronary event, which leads to the heart failure if it causes more than 40% involvement of the heart, which causes heart failure symptoms. Also, due to the inflammation, immune activation, it causes myocarditis. Myocarditis itself may cause, pancarditis, myocarditis itself may cause heart failure. Also, it causes myocardial dysfunction, damage, which may lead to arrhythmias. Once patient has COVID, the risk of cardiovascular disease, getting acute coronary syndrome is very high. Now coming to the once patient gets the myocardial infarction, how we will go? Patient presents to the emergency department, to the hospital. First, we have to rule out the other causes of XT segment elevation MI, because many of patient may have pericarditis, myocarditis, which may show ST segment elevation in ECG, but he is not having a myocardial infarction as such. It mimics the ECG mimics the ST segment elevation MI. So we have to rule out those causes first. Then when patient comes to ED, initial evaluation should be done immediately, as Dr. Sachin Yadav sir very beautifully narrated that ECG should be taken within 10 minutes. Then the patient should be evaluated thoroughly before activation of cardiac cath lab. Appropriate risk factors should be accessed. Patient should give a face mask so as to prevent a droplet infection to the cath lab technicians and cath lab healthcare workers. All the CCL staff, physicians should have appropriate PPE kits for safe performance of procedure. That we know: gowns, gloves, full face mask, N95 respirators. The patient should be thoroughly evaluated. If patient is having respiratory compromise, the intubation should be done in emergency department itself. It should be avoided intubation in cardiac cath lab. If it has to be done, then everybody in all the staff should be using PPE kits. PPE proper training to get to wear the PPE kits should be given to the staff. We all know donning and doffing very well. It's very routine for us, guys. Now coming to the strategy which we will be using in patient with acute myocardial infarction is the primary percutaneous intervention. That is the angiography followed by angioplasty is the mainstay of treatment. If PCI is not available, primary PCI is not available, and patient is not having any contraindication for fibrinolysis, then fibrinolysis is recommended, followed by early angiography and early intervention, which is also called as pharmacoinvasive approach in the treatment of acute myocardial infarction. Now coming to the principles of STEMI management in COVID-19. All the patients who are coming with acute myocardial infarction should be considered potentially infected with COVID-19. So irrespective of reperfusion strategy which we will be using, patient should undergo the testing for COVID-19 in the form of RT-PCR or rapid antigen test. The maximum delay from STEMI diagnosis to the reperfusion should be 120 minutes. If it is very nicely elaborated by Dr. Sachin Yadav. I won't go in detail in this strategy. Actually, I have skipped the slides. It is 120 minutes. in this pandemic, due to the availability of logistic and other things, they have increased 60 minutes time delay for this total ischemic time. Generally, it is 120 minutes. We can add 60 minutes in that. If the total ischemic time, we cannot shift patient to the cath lab within 120 minutes to 180 minutes. Fibrinolysis, if it is not contraindicated, is the first line therapy, followed by patient once get stabilized. We have to do early angiography within 3 hours to 24 hours. If after fibrinolysis patient is not settled, that is, we repeat ECG after 60 to 90 minutes. In that, ST segment is still elevated more than 50%. So, and patient is having chest pain. We call it as a failed thrombolysis, and we take this patient for rescue angioplasty. Immediate complete revascularization is indicated. After once we do angiography, we see for the culprit vessels, we fix the culprit vessels, and which are non-culprit vessels. Generally, what we do generally is we do the stitch procedure before discharge. After second or third day, we go and fix the another vessel which is not culprit. But here in COVID-19 pandemic, what EAC has recommended to do complete revascularization at the first time itself. So there is no staged procedure as such. All physicians involved in the management of patient with STEMI should be familiar with indication, contraindication, and the dosages of fibrinolysis, and they should adhere to the established protocols. So here patient coming to the hospital where cath lab is available, and so it is advisable to go angiography followed by angioplasty within 120 minutes. If it is not available, so it is considered to shift patient to the cath lab facility available hospital within 120 minutes. If it is not available, so thrombolysis or the fibrinolysis is recommended. Now coming to the NSTEMI patients. NSTEMI means non-ST segment elevation MI. The patient's ECG is not showing any ST segment elevation, but troponin levels are on higher side. So first we have to see whether patient is having COVID-19. Along with that, we have to rule out the myocarditis, which may give false positive troponin levels here. If it is not there, it's a true NSTEMI patient. Then we have to risk stratify this patient into the high risk, very high risk, intermediate, and the low risk subsets. The patient who are at a very high risk, in those the hemodynamic instability is there, or patient is having cardiogenic shock, or patient is having chest pain which is refractory to the medicines, or patient is having life-threatening arrhythmias, cardiac arrest, or patient having mechanical complications like a mitral regurgitation or VSR, ventricular septal rupture, or patient is going in acute heart failure. These are the indications for activation of cath lab and early invasive procedure. These are the high risk subset. Now coming to the just high risk subset, in that patient who are having dynamic STT changes or recurrent symptoms, in those we can wait, we can do the COVID-19 that swab test. If swab test is negative, then early invasive strategy is recommended. For intermediate risk and the low risk subset, first we have to do the RT-PCR for COVID. If it is negative, then go for non-invasive testing like stress test or myocardial perfusion imaging. Along with this, for risk stratification, we use GRACE score. GRACE score is the score, if it is more than 140, we consider it as very high risk, and we shift patient directly to the early invasive strategy. Now coming to the issues which require special attention while management of ACS during the COVID-19 pandemics. In severe COVID infection, coagulation parameters are deranged. So it should be kept in mind before giving thrombolysis or antiplatelet therapy. Close monitoring of bleeding profile or the parameters should be done in these situations. Then now coming to the antiviral therapy like remdesivir, lopinavir, and ritonavir, which was used earlierly. These antiviral drugs may prolong QT interval, PR intervals. So baseline ECG, if there is prolonged QT, those drugs should be avoided. Then anticoagulation therapy like a rivaroxaban and apixaban, they should not be, or the dose should be reduced, or the drug should be avoided if they are used with antivirals. Then antivirals used with along with ticagrelor, particularly, basically it increases the serum concentration of ticagrelor. So it is advised not to use ticagrelor in patients with a COVID-19 infection who are receiving antiviral therapy, basically. If we are giving clopidogrel along with antivirals, the efficacy of clopidogrel decreases. So the platelet inhibition is not sufficient. So that should be kept in mind. If we are administrating antiviral drugs with statins, routinely we give atorvastatin and rosuvastatin. Antiviral may potentiate the statins, and it may result in myopathies. So it should be kept in mind to reduce the dosages of statins. Thank you very much. So to summarize here, the rates of acute myocardial infarction during this COVID era has come down. The patients who are coming to emergency department are reduced. But if patient is COVID positive, in that patient getting acute myocardial infarction, the chances are very high. The reasons we have seen because of plaque instability, cytokine storm, and inflammation, it all causes, and the hypercoagulable blood, it all causes increased risk of COVID. Primary PCI is the choice of therapy if it is not available. So the fibrinolysis should be given as early as possible. We have to keep in mind while using antiviral therapy, few drugs should be avoided, or the dosages should be reduced. Thank you very much.
Thank you very much, sir. We'll take the question answers last.
Sir.
Dr. Sachin Batra, sir, should we go for the final talk by you?
Yes, sir. Just one question is there regarding COVID, and then we'll go for the
final talk.
ARB statin colchicine. Onkar sir, it's for you. ARB statin colchicine in COVID myocarditis and in MI also. COVID STEMI primary PCI versus pharmacoinvasive therapy. Has there been incidence of bleeding with triple antiplatelet therapy and anticoagulation during the COVID times? This is the question from Dr. Amit.
Can you repeat, please?
Role of ARB statin.
Which are separate.
Yeah, 3 questions are separate.
Okay.
ARB statin and colchicine in COVID myocarditis and MI.
1 minute, I'll just.
You can see it on the question.
Yeah. So has there been increased evidence of bleeding with triple antiplatelets and anticoagulants during COVID times? So we have not witnessed increased bleeding as such during COVID times. If fibrinolysis is given and antiplatelets are given, that is what may be the question, I think, followed by anticoagulants. So we have not witnessed increased in bleeding. This is one question. COVID STEMI, primary PCI or pharmacoinvasive therapy. basically the golden hour, the first hour is golden hour, and first 3 hours the response to the fibrinolysis is as equal to the primary PCI, so it is considered. But the reocclusion rate after fibrinolysis is very high. Patency rate is overall same, but the reocclusion with pharmacoinvasive therapy, means giving fibrinolysis and waiting, that reocclusion rate is very high. That's why it should be avoided. We recommend to go for primary PCI with the expertise. Then ARB, statin, colchicine in COVID myocarditis and MI. So colchicine, I am really not aware of. Dr. Lakre sir, if you know.
No. Yes, Omkar sir, few of the myocarditis, not COVID myocarditis. There have been studies for the colchicine, and for few studies are there for the COVID. COVID, there are where they have used colchicine, but I'm not also aware about the COVID myocarditis where the colchicine is used. Yeah, prevention and few studies are there for ARBs and even for the statins for the COVID myocarditis. And obviously we give in all MIs with COVID, we administer statin as a high dose as our routine protocol whenever indicated ARBs or AC inhibitors.
Okay, thank you, sir.
Thank you, sir.
Thank you, sir.
Thanks for all the explanations given by both of you about colchicine and other things. And I request now our last batsman, I would say, Dr. Sachin Lakde from Hridayalaya. हृदय स्पर्शी म्हणायला हरकत नाही, शेवटचा टॉक. Dr. Sachin Lakde is MD Medicine, Cardiology, well-known cardiologist in city of Pune and Maharashtra, I would say, practicing Pune for last 10 years. He is panel cardiologist in Ruby Hall, Pune Hospital and Sahyadri Hospital. Director of Hriday Sparsha Cardiac Cath Lab, Cardiac ICU in Sangli also. He has more than 15 publications in national international journals. So also he is Associate Professor in Department of Cardiology at Bharati Vidyapit Medical College. He is also postgraduate teacher, and I feel he is the best teacher also. I heard him many times. He is very much interested in social activity and preventive aspects in cardiac diseases, for which he has conducted more than 100 camps and workshops. So I request Dr. Sachin Lakde sir to elaborate us and address on recent advances in management of heart failure, role of SGLT2I, that is dapagliflozin. Please, sir, continue.
With all the previous speaker, it's especially in this COVID era, I would be presenting a relatively very unusual and hot thing about the heart failure, which is also an important part of recent advances, especially the role where the newer drug SGLT2 inhibitor dapagliflozin has been played very important. So we all know about the is a drug for the drugs which are used for the diabetic patients. So we all know about the India being second in the world with diabetic patients. We also know about the evolution of diabetes from initial days of when the insulin was in 1950s. The oral anti-diabetics were discovered, metformin and sulfonylureas. In 2005, breakthrough was done with the DPP-4 inhibitors. In 2020, where the cardiovascular safety were seen with the DPP-4. inhibitors. In 2012, when the SGLT2 inhibitors came into the market, and a lot of research was done on that molecule, where it had shown multiplication technology in the telephone, where the cordless then got the simple mobile phone. We could do messaging also, not about the talking to each other. Then came the smartphones, where the many things were beyond our talking and the messaging to each other. The future technology remains with all the available tools. We can go ahead further. So all the whenever this diabetic treatment has also has revolutionized in this kind of situation. So this SGLT2 inhibitors, which are one of them is the dapagliflozin. These are newer oral antidiabetic agents, where action is the SGLT2, which is sodium glucose co-transfer, which are there on proximal convoluted tubules, and it removes the excess of glucose from the urine. And this molecules act on this SGLT co-transporters, and it's the action is independent of the insulin. Various drugs are available. We all know, you must have heard from physicians, diabetologists, dapagliflozin, rimogliflozin, canagliflozin, empagliflozin. These are various molecules in this SGLT2 inhibitor group. Beyond doubt, this, if you use as monotherapy SGLT2 inhibitors, or addition to the metformin or sulfonylureas, it shows HbA1c reduction of almost around 0.5 to 1% of HbA1c reduction is there. It also has shown to be the body weight is reduced in the patient who are on monotherapy or additive therapy with the SGLT2. Even there is weight loss from the fat mass, where the lean fatty tissue which is protected, and the fat loss is there with the this dapagliflozin SGLT2 as compared to placebo and metformin. So blood pressure was also reduced. So why everybody must be thinking why the cardiologist is talking about some diabetic molecule, and it's like the role was when if we compare this was like a Dhoni who was by chance in Indian team came as a substitute to as a wicketkeeper to Dinesh Karthik, but overall to be a best, a great batsman, great finisher, great captain. We all know about his history. A similar kind of thing happened with the dapagliflozin, where the study was for the diabetic reduce the CV death and heart failure, and that was very significant, where the dapagliflozin was used versus the placebo, and we can see overall MACE was also reduced with the dapagliflozin. So that's the importance in cardiovascular diseases of this dapagliflozin. So even with the prior MI, patients with prior MI and type 2 diabetes, that had shown a lot of benefit with dapagliflozin. This was the DECLARE trial, DECLARE TIMI 56 trial. So overall, the CV deaths and heart failure was reduced. Heart failure CV deaths, so all-cause mortality was reduced with the dapagliflozin, where we can see the purple color is of dapagliflozin uh, versus the placebo. So out of all these SGLT2, dapagliflozin remains the important, where we can see all the components extensively studied. All these features are seen versus rest of the canagliflozin, empagliflozin, or remogliflozin, which has recently been canagliflozin. They have been extensively studied, but few of the things about the renal benefits are not as great as dapagliflozin. And if we compare to a DPT or inhibitor, which is also extensively studied, has cardiovascular benefit, but as compared to dapagliflozin, it has limited studies. So dapagliflozin is just, we summarize what I will talk about the things, is the insulin independent action. It's not related to insulin. It acts on proximal convoluted tubules. There is HbA1c reduction, systolic blood pressure reduction, weight reduction, cardio-renal benefits are there. Good safety, tolerability is good. Quick action is there. So if we see for all the diabetic guidelines, whether it's the ADA or European guidelines, Indian guidelines, they have put as a monotherapy, we can use SGLT2, or even with adding add-on therapy, dual or triple therapy in diabetic patients. So if we see, especially with the especially with the patients with established ASVD, there is some prior MI, prior angioplasty, or the patients coronary syndrome or ischemic heart disease, or patient with heart failure, the SGLT2 has shown beyond has definitely been
सब बंद होगा ना, कल सुबह फोन करो.
SGLT2 have been a very important role in patients with diabetes. So we come to how exactly the things are there with dapagliflozin in heart failure. So we can see heart failure is very concerned, serious issue. 1 in 5 people develop heart failure during their lifetime. And the mortality and morbidity, despite of so many advances, so many of medications, so many of available devices, so advanced things are there with even the cardiac transplants, the mortality remains the high. And mortality at the time of diagnosis is after the diagnosis is around 50%. So 50% of people will die once the heart failure is diagnosed within 5 years. So mortality risk is also similar to other common cancers. So we can see in this graphical representation bar chart where the heart failure mortality in prostate or breast cancer. So we should not neglect heart failure patients, and we have to take utmost care. If we come to Indian scenario of heart, there are almost 8 to 10 million patients with heart failure in India. Around 1% of adult population is of heart failure. And if we see post-admission, the mortality is around 20 to 30%. Many being reason medication adherence, and one more important thing is the young population. Indian heart failure patients are relatively young as compared if we see in the Western. And another important finding there was in Trivandrum heart failure registry that almost 50% of heart failure patients were diabetic. So this was very important aspect of Indian prevalence of heart failure. So we'll go to the most important that decreases the mortality. If we categorize this in two groups, like which is recommended as of now in 2020, there are the which decreases the mortality, drugs that decreases the mortality, and drugs that improve the symptoms without worsening of the outcome. Means diuretics. If we take diuretics, the symptoms will be reduced. Loop diuretics, especially where we give or the drugs like torsemide, even digoxin, it will improve the symptoms, but it doesn't decreases the mortality of the patients. So what are the drugs that it decreases the mortality are the ACE inhibitor, ARBs. This either of this has to be in the prescription. Mineralocorticoids, isosorbate dihydrolysine, ivabradine, and omega-3 fatty acid also is a questionable thing. But ACE inhibitor, ARBs, either of them, mineralocorticoids, and beta blockers. So if we see the ACE inhibitor and beta blockers in management of this is the chart where they envisage class 2 to class 4 patients of heart failure and beta blockers as indicated. Apart from this, the implantable cardioverter defibrillator CRT devices like this, which certain criteria are there, and then we study about the heart failure when the patient is not responding to the standard therapy for the heart failure, where the good amount of beta blockers are given, ARBs are given, and then we consider this patient if the criteria are fit, the ejection fraction is less 30%, then we can consider for the CRT or ICD. Apart from this, if the symptoms are not getting improved, then we consider the patient for either heart transplant or the left ventricular assist devices, where the left ventricle is assisted with certain kind of devices where the advanced therapy, costly therapy, and many things, many of our patients might not be affording for this kind of devices. So we'll come one by one. How much the mortality is reduced by the when I'm talking about the heart failure, this is the ejection fraction is less than 40%, 45%. The resort ejection fraction or heart failure, where the diastolic heart failure, I'm talking about this, everything about this systolic heart failure. So if the mortality, if we see with these drugs, if we see the ACE inhibitor or ANB, it's around only 15 to 20%, less than 20% we can say. And if we see for the beta blocker, it's around 35 to 40%, and mineralocorticoid, it's around 25 to 30%. So when we consider this, when many of the heart failure patients, the blood pressure will be like between 90 to 100 systolics. Many of them might not be tolerating ARBs or beta blockers. In that case, if we want to introduce, it's always the beta blocker which gives the maximum benefit, and in all the heart failure patient, it has to be a first prescription for any patient. Second would be the ACE inhibitor or ARBs. It gives the modest benefit, and the mineralocorticoids, where the spironolactone or eprilumab, which are the drugs which are available as mineralocorticoid antagonists. So to replace this, to add this benefit, there have been a drug called as sacubitril valsartan combination, where it's called as ARNI, which was studied extensively in the paradigm shift, where it was compared with ACE inhibitor enalapril, and that has over the, it's up and above the mortality of the ACE or ARBs, where you can see ACE ARBs are around 15 to 18%. This has added another 20%. So ARNI or what we call angiotensin-neprilysin inhibitor has added the many things beyond the ACE or ARB. So this ARNI, just to highlight that ARNI has changed the paradigm shift in the management of heart failure with patients with reduced ejection fraction. That's the systolic heart failure. So where comes this role of dapagliflozin in management of heart failure? We have seen this heart failure patients, type 2 diabetic patient, which was the trial which was conducting benefits to reduce the mortality or all-cause mortality, CV deaths, and heart failure. That gave the booster for the further trial of DAPA-HF, where the background was that SGLT, that's the sodium glucose co-transporter, inhibit prevention of development of heart failure in patients with type 2 diabetes, and it can be used to treat established cancer. So it was studied whether we can use this where the heart failure was prevented in the patient who are diabetic patients, and can we use this as a treatment for the heart failure. Then another question to be addressed was the benefit of SGLT2 inhibitors. Are they glucose independent? Can SGLT2 inhibitor be used in type 2 patients without type 2 diabetes? So even without type 2 non-diabetic patient, the use of dapagliflozin was studied. So SGLT2 inhibitor, dapagliflozin 10 milligram was added to standard therapy in patients with systolic heart failure, both with and without diabetic patients, where type 2 diabetic patients were studied. This was DAPA-HF trial. DAPA is the dapagliflozin for that, and HF is the for the heart failure. The study design is the good number of patients, around 4,700 patients, randomized 1:1. The criteria was, I won't go into detail of this. Class 2 to class 3 in NYHA, ejection fraction was less than 40%, BNP levels were raised. Placebo versus the dapagliflozin of 10 milligram was used. So important was that patient with diabetic and even the non-diabetic patients were there. This was the global trial where the more than 20 countries were involved. Even the Asian population, Indian population, were even from patients from Pune were there. We were the sub-investigator for this study for a small period of time. And these were the parameters. I won't go detail. And with this kind of this in last year, November 2019, in NEGM, they published it, the results, and dapagliflozin was approved for the patients with systolic heart failure. So the primary outcomes were CV deaths were reduced. Hospitalization for heart failure was recurrent admissions are very common with the heart failure patient. If we see patient remains stable for 1-2 months, he again goes into heart failure, and then you have to readmit this patient. And this kind of things were reduced, and even the patient who comes with fluid pulmonary edema or heart failure, that incidence was also reduced with this molecule. Worsening of even patients, the worsening of the heart failure was also reduced with dapagliflozin, which was very significant as compared to placebo. So other things like patient psychology. Basically, if we see the even the morbidity with the patients of heart failure, if you see they are dependent, and they have many comorbidities associated with. So the psychology also depends and quality of life also is worse with the patients with heart failure. This was also studied, and it had shown a very much benefit with the dapagliflozin. So whenever we have some new molecule, we have hundreds of questions. What are the side effects and safety profile? With all kind of things, the rate of there was lower. See, this acts on the proximal convoluted tubules, and the chances why there is glycosuric effect and the urinary tract infections are were initially seen much more, especially the Fournier's gangrene, which was the red box warning on the all SGLT2. And this was also studied, and it's hardly any lower urinary tract infections were also lower rates were there. We think would it have been a volume depletion, but that was also not significant, or any other imbalances like amputation or bone fraction or hyperkalemia or any malignancy. This was not seen in any of the patient, and dapagliflozin has been studied in more than 13 placebo-controlled studies with up to 102 weeks follow-up, and there was nothing this kind of things versus the placebo and the dapagliflozin now. So relatively a safe drug, but few care has to be taken when you give the dapagliflozin. Especially the genital tract infection, we have to educate the patient to get the genital hygiene clear, and educate about the maintenance of hydration. A few things we should not do with this molecule. Do not use in type 1 diabetes, which has no role in type 1 illnesses, or do not drastically reduce the insulin dose, or but we have to adjust the dose of the sulfonylureas and the diabetics. This subgroup analysis, where the surprising thing, though this molecule is a diabetic molecule, even for the non-diabetic, same efficacy for patients with heart failure. Dapagliflozin, even for the non-diabetic patient, was also beneficial, and even the reduced GFR less than 60%, the dapagliflozin had also benefited. Acute kidney injury progression was also less with dapagliflozin as compared to, so many of the patients with heart failure, they have advanced renal diseases and
technical issue about
like dapagliflozin has some protective role in acute kidney injury. This slide LT2 inhibitor. So this dapagliflozin has been even by the Agnew Cornwall and Deepak Bhatt in peer review of metabolic cell metabolism. They have recommended dapagliflozin for even diabetic and non-diabetic patients. Even for the Canadian Cardiovascular Society has recommended for heart failure patients. Even European Society has recommended heart failure patients. And FDA has given the approval for dapagliflozin for the only SGLT2 molecule for being a diabetic, but still a diabetic molecule. It has been given the benefit of they have approved it for the patients with heart failure with and without diabetes. So just to conclude few things, dapagliflozin, it's a recently a new molecule in management of diabetes, SGLT. It's belong to SGLT2 molecule group of anti-diabetic. As we have seen, there is no doubt that it works as an anti-diabetic. It reduces the sugar levels, improves the lipid parameter, blood pressure. It also improves the has less episodes of hypoglycemia, along with other current available anti-diabetic drugs. Reduces the weight loss is there with the patients, and most importantly, the in patients with it has shown proven benefit in patients. It reduces the episodes of heart failures, cardiovascular deaths. It improves symptoms in patients with heart failure when added to the standard therapy of the heart failure therapy. And another important, it's even used in patients with the, we can safely use in patients with the even non-diabetic patients with systolic heart failure. That's what the molecule has great. And I mean to say this all my thoughts about the heart failure, recent advances, and about the especially SGLT2 molecule dapagliflozin. Thank you.
Thank you very much, sir. Though with the technical hassle, I would say it was a very lucid presentation.
So,
it was an academic feast for all the delegates. I would say about 80% attendance, I would say. And all of them were till the end for your information. So should we conclude?
Yes, sir.
If any questions, you can get in touch. We can answer that on WhatsApp. And I request, sir, we can send that question answers also on the mail, and you can get all your queries solved. So I thank all the faculties and all the delegates who have joined. We should conclude. May I request our President, Madam?
Yeah.
She has anything to say?
Does Dr. Lakde sir wants to answer the questions?
No, ma'am. Just I want to thank IMA Pune and all the IMA members for attending this. Sanchiti sir, Ingle sir, and Madam you, and even Omkar and Sachin Yadav sir for joining this cardiology update with this. Thank you for giving us opportunity.
Lakde sir, those who are not the IMA members, please ask them to become IMA members.
Okay.
From your heart mitra.
Yeah, they are there. They are from the.
If they are, it is very good.
Yes, they are. They are the IMA members, ma'am.
Yeah. Thank you.
Is Dr. Sunil Ingale there?
He left, I think.
So. Shirsagar, madam. Okay. So I think, President, madam, I'll give vote of thanks.
Yes.
Okay. So I first thank Dr. Sachin Lakde, who took the initiative. We were after him so many days. Heart is calling to you, and he had answered the call for Hriday Sparsh. Secondly, I would like to thank Dr. Sachin Yadav for joined and enlightened us on improvement in care and ST elevation, myocardial infarction. Dr. Krishna Dhut, Dr. Akash Mukhi, Dr. Omkar Thopte, all the young dynamic team, we are really grateful indeed. Thank you, sir. And
thank you, sir. Thank you very much.
Thank you, Omkar Thopte, sir, also.
Yes, sir. Thank you. Thank you.
I don't think I forgot anyone, but thanks a lot. Thanks, Dr. Sachin.
Thank you, sir. Thank you very much.